I have the pleasure of introducing our speaker today. Dr. Fanucchi is a board-certified physician in internal medicine and addiction medicine. She provides treatment for opioid use disorder in the UK Bluegrass Care Clinic and the UK First Bridge Clinic. Dr. Fanucchi's research focuses is in integrating evidence-based treatment for opioid use disorder in medically complex patient populations. She has presented regionally, nationally on the management of hospitalized patients with opioid use disorder and provides trainings to physicians and other members of the healthcare team. Dr. Fanucchi is also a co-investigator on the treatment team of the Healing Community Study. Welcome, Dr. Fanucchi.
I have no disclosures. Practice gaps for today. We're going to review that medications for opioid use disorder are effective but underutilized treatment that can save lives and improve quality of life for people with OUD. Despite the evidence that MOUD saves lives, behavioral interventions are often used alone in a treatment plan or as a requirement to gain access to MOUD. Understanding behavioral interventions in the treatment of OUD and as a supplement to MOUD will improve patient outcomes. We're going to explain how to incorporate behavioral interventions into a treatment plan with medications for opioid use disorder, explain the efficacy of different behavioral interventions in the treatment of opioid use disorder, describe the basics of contingency management, cognitive behavioral therapy, and community reinforcement approach in the treatment of opioid use disorder. And we hope that you'll have an enhanced understanding of the role of behavioral interventions when treating persons with opioid use disorder. So why do we emphasize medications in treatment of opioid use disorder? In short, they save lives. So counseling alone or treatments that don't include medications are not effective and increase overdose deaths. Medication management of OUD includes basic counseling. Some people with OUD certainly do benefit from additional counseling. The problem is that we don't know who will necessarily receive additional benefit, nor what specific modality of counseling will be most helpful for an individual person. So looking at methadone, we have decades of data and decades of evidence that people with opioid use disorder who receive methadone treatment compared to those who do not receive medications are more likely to survive. So this is a 8-year study. The top line, and this is the percent of people alive over those 8 years. So these are folks that receive methadone treatment and those that left treatment voluntarily over time. And these are those that were randomized to not receive medication. And you can see that very quickly, there's a dramatic increase in the number of people that are dying in the group that did not receive methadone. For buprenorphine, this was a seminal study where people with opioid use disorder were randomized to buprenorphine taper versus buprenorphine treatment. And both groups received a lot of additional services, including counseling. And this is the number of people remaining in treatment. So this was 20 people in each group. And you can see that from the beginning, those that were receiving the buprenorphine continuously were much more likely to stay in treatment. And in this very small group study, 4 of the people in this group had died of overdose within 2 months. It's a very high mortality rate. You've seen this slide before, I'm sure, but overall, when we lump methadone and buprenorphine together, there's a dramatically reduced risk of death. So if we place the risk of death at any given time in the general population, we place it at 1, so averaged across general population. People with opioid use disorder have about a 6-fold increased risk of death at any given time. When people with opioid, compared to the general population, when people with opioid use disorder then initiate medications and stay on medications, specifically methadone or buprenorphine for opioid use disorder, their risk of death does not go down to 1, not down to the same as the general population without opioid use disorder. but it is reduced dramatically to less than twofold. So from more than sixfold to less than twofold, the risk of death of the general population. It's a huge mortality reduction. This is just a slide to note that counseling is required in methadone treatment per regulation. Now, the state level regulations for methadone treatment are currently being revised, but as they stand now, for the first phase of methadone treatment, counseling is required weekly, and then thereafter required monthly. Federal regulations allow people starting, entering methadone treatment to begin medications without counseling if, for example, the counselors already have the full number of patients that they are able to have on their census, and there's a waiting list for counselors at the OTP. The federal regulations allows that patients can start medication on an interim basis without the counseling requirement for up to 120 days, instead of being also put on a wait list for medication. And those that receive that interim methadone are much more, without counseling, are much more likely to stay in treatment compared to those that are placed on a medication and counseling wait list. So this is just to illustrate that counseling requirements should not delay starting medication. This was a study done in a similar concept, but instead of interim methadone, it's interim buprenorphine, where when people are wanting to enter treatment with methadone. So in this study, people were trying to seek treatment with methadone, and there was a waiting list, probably usually for the counseling requirement. But instead of being placed on a waiting list for methadone medication and counseling, they were initiated on buprenorphine. And the number of people that then had reduced illicit opioid use was dramatically lower in the group that received interim buprenorphine compared to the group that was just placed on the waiting list. So again, that illustrates the importance of initiating medication in helping people enter treatment, stay in treatment, and reduce the risk of overdose deaths. So I wanted to review a case to kind of set the rest of the talk in context. So this is a 54-year-old man with a history of cocaine use disorder since teenage years, and he developed an opioid use disorder in his 20s. He also had nicotine dependence, HIV, hepatitis C, high blood pressure, and high cholesterol. He was recently incarcerated, and coming out of jail, he desired treatment for substance use disorders. And in his words, he thought that heroin was the problem, but that cocaine he could stop. So the goals of behavior change in substance use disorder treatment are to decrease drug seeking and drug taking behavior and increase time spent in activities with non-drug using social supports. Motivations for people entering treatment are really complicated and sometimes conflicting, and ambivalence is very, very common. So I often will hear from providers and also sometimes from patients that, well, they're just not ready enough. And I think it's important to recognize that in substance use disorder treatment, it is very, very common and really very normal for someone to enter treatment and they have a lot of ambivalence about entering treatment. And that does not mean that they're not going to be successful or that they're not going to be able to decrease their risk, decrease the use. So, we have to think about substance use disorder treatment as on a continuum. It's not all or nothing necessarily. So our patient begins treatment for opioid use disorder with buprenorphine, 16 milligrams, which also his visits include medication management, which again is brief counseling from the prescribing clinician. He restarts treatment for HIV and attends his appointments as scheduled, but he continues to use cocaine. So what are some of the behavioral approaches to consider to help reduce the number of days of cocaine use? So we do have some, we do have data that adding counseling to medical management of buprenorphine treatment doesn't make a huge difference in opioid use disorder treatment outcomes. So over 6 months, this is a study looking at adding cognitive behavioral therapy to buprenorphine in addition to the standard medical management, and there was no additional benefit to CBT. There was another study looking over 8 months for cognitive behavioral therapy and contingency management, as well as a combination of the two that also showed no additional benefit over the medical management visits. And a third study that looked at medical management compared to medical management plus individual drug counseling. And in all of these studies, intervention groups with more intensive counseling demonstrated similar rates of reduced opioid use as medical management. This was a large, this was a randomized clinical trial looking at buprenorphine in primary care compared to with medical management compared to two other groups of buprenorphine with medical management where they got enhanced counseling approaches and more frequent visits. And essentially what this shows is that all three approaches were equivalent. There was no additional benefit in adding more intensive counseling to buprenorphine treatment in primary care. So does this mean behavioral interventions don't work at all? Well, no. Medical management in buprenorphine treatment is counseling. So nobody is recommending a model where patients are simply just handed a prescription and no medical management at all, where they just receive a prescription and walk out the door. So medical management in buprenorphine treatment includes an assessment of how the person is progressing in treatment, how the medication is working, and if they're experiencing any side effects, monitoring of treatment with urine toxicology testing, assessment of symptoms of craving, withdrawal, pain, reviewing coping strategies, and working one-on-one with the patient to develop coping strategies for symptoms, triggers, and cravings. There's screening and treatment and a referral for anxiety and mood disorders or any other psychiatric disorders. There's encouragement of participation in recovery support activities as well. So some patients benefit or may be interested in additional behavioral interventions. And so the ones that are more effective generally incorporate positive reinforcement approaches. So generally leveraging the behavioral concepts of rewards and consequences. So I'm going to ask a question of the group. Can you all think of some things that generally in behaviors positive reinforcers? And that would mean that a reward is given when a behavior is observed to encourage the behavior to continue. And this doesn't have to be necessarily in substance use disorder treatment. It can be kind of in life in general. You can enter them in the chat or come off mute. Yeah, so that's great. So star chart, yes. So positive reinforcement in dog training is definitely very effective, and humans respond to very similar things. So, you know, John is using a star chart. My kids are older, so we're leveraging screen time and treats. Gift cards are absolutely positive reinforcement. Money is a big one. Yep. So Whitney is describing essentially contingency management, which we'll talk about a little bit later in the talk, but that's exactly a form of positive reinforcement. So thank you all. And overall, although it has unfortunately been a part of the addiction treatment landscape over historically, punishment and shame are not effective in eliciting positive behavioral change. So we're going to go back to some basic behavioral concepts. So classical versus operant conditioning. So classical conditioning is where a previously neutral stimulus elicits an involuntary conditioned response. And the most well-known example of this is Pavlov and the dogs, where in the beginning you ring a bell and the dog doesn't respond at all. But then every time you feed the dog, you ring the bell, and the dog then unconsciously associates the bell with food. And so then ringing the bell elicits salivation from the dog. And so that's an example of classical conditioning. Operant conditioning is when reinforcers or punishments alter the frequency of a voluntary behavior. So the dog didn't have a choice over salivation. This happened as an involuntary reflex from the brain associating the sound with being about to eat. So in this example, operant conditioning, I'm going to play a little audio here. Anyone recognize that sound? Did it make you cringe a little bit? Well, anyway, it's supposed to be it's a dentist drill. And for many people, it kind of gives a like, oh, that's horrible. But the dentist pediatric dentists often use positive reinforcers to reward the very unpleasant experience of coming to the dentist. And this happened in my family when, the dentist was giving my kids these little like tiny toy animals, and they were creating these elaborate animal structures with these little toys that they would get from the dentist. And then one day I got a note from them to request dental appointments from my children. And so that's an example of operant conditioning, where the positive reinforcer of receiving the toy meant that my kids were then voluntarily requesting to go to the dentist. So contingency management, which was noted in the chat earlier, is based in that concept. So the idea is that when we add positive reinforcement, so we add a pleasant stimulus, receiving a toy or a treat or money in the hope of increasing a positive behavior. Whereas a negative reinforcement is you remove something that the person does not want to also increase the frequency of the behavior. So in the case of addiction treatment, you might say, well, you can come in less frequently if you, with increasing adherence, and we see the substances that are not that are being used are less frequently present, that you're using less, then you can be rewarded by not having to come to clinic as frequently if that's something that is desirable. And then there are some negative parts of it, where an adversive stimulus might be put in to reduce a behavior, but these are less effective in terms of behavior change, and so really contingency management focuses here on the more positive reinforcers. So again, in contingency management, you identify the target behavior, and really the target behavior here might be reduced cocaine use, for example, in somebody who is receiving treatment for opioid use disorder with buprenorphine. The target behavior, and they're also using cocaine, that the target behavior might be reduced days of cocaine use and ultimately no days of cocaine use. And so you have to have a way to measure the behavior. So that would be with urine testing and self-report. And then you provide tangible reinforcers. So a token, a ticket, clinic privilege, a gift certificate. And in the classic example, you can have escalating value of rewards. So this is a fishbowl model where each of these tickets is worth different values. There might be a whole bunch of, say, $1 tickets. There might be a smaller number of $5 tickets and a smaller number of $10. And then maybe in there might be like one $25 or $50 ticket. And with increasing, as the desired behavior happens more and more with each visit, the person may get an increasing number of draws from the fishbowl to then increase their chances of receiving the higher number of the higher monetary value ticket. And so then those rewards can be withheld when the behavior doesn't occur, or maybe you start back from the beginning where you get only one pull from the fishbowl. So this is a little video example of contingency management. John, if I pull this up, will it still be sharing here?
Did you share your whole screen or just the application?
Just the application. So then it won't, right?
Yeah, you'll have to stop sharing.
Okay.
Yeah, sounds good. Excellent. Okay. And Jake, take your bucket. Okay, first row. What do you got? Small. Good job. All right, nice. Go back in there. What's this? Small. Small. Great. Good job. Small. Oh, what's this?
Large. Hey, all righty. That's one
Excellent.
that I like.
Good job. So that's two small and a large. So let's stand up here.
Okay.
Have you look at our cabinet?
Okay.
There we go. Sorry, got a closed door.
Ah, man.
And grab your small and large product.
Okay, small here. Okay. Oh, wow. What a decision. I don't even know mac and cheese. Oh, I'll take these guys. Oh, where's these? Oh, no. This, the lips. I'll
Excellent.
take lips. Okay.
And you
And
can get another small too.
so one more small. Is that a whole cup full of goodies?
Oh, they're just one each.
Just one. Okay. Oh, well, oops. I'll take the gloves.
Great.
And you sells this time of year. Okay.
And a large?
And a large. Is that this shelf?
Yep, that's that second shelf.
That's that one there. Okay. What's this here? Oh, we'll take this one.
Fantastic.
Okay.
If you're a Kentucky homeowner, 2022 is your last chance to go solar.
Well, now we
In
get
December of 2020, Congress passed an extension to the solar investment credit, which pays homeowners an
Sorry about that. YouTube went to a thing. Okay, let's me go back to the PowerPoint. Okay, so you all get the idea. That person was able to get, she had 3 pulls from the fishbowl and she got 2 small value rewards and 1 higher one. And then she was able to choose from the rewards cabinet what she wanted to take home. So this is a study that looked at contingency management and treatment of opioid use disorder. And this is 162 patients in treatment in Connecticut, and they all also had cocaine use disorder. And there are 4 treatment groups: double-blinded buprenorphine or methadone, and then they got contingency management versus performance feedback. And essentially, methadone plus contingency management was most effective at having the proportion of drug-free urine tests, meaning cocaine negative urine tests, and over successive intervals. And then in the buprenorphine treatment, contingency management was also more effective than just performance feedback, but over time that difference kind of went away. So it was effective in the beginning and then kind of went away over time. So overall, when we look at contingency management studies for other drug use, not opioid, but opioid with something else during medication treatment for opioid use disorder, overall contingency management does improve the duration of abstinence from the other substance and the proportion of negative urine samples, but it's not, 100% effective across all populations and all substances. So if we return back to our patient, we're now 6 months into treatment. Some things are going very well. So he's still taking buprenorphine, 16 milligrams. He's not had any other opioid use. HIV is controlled, and as well as high blood pressure. He's gotten housing and he obtains a part-time job. But some challenges continue. He has near daily cocaine use. He's still smoking cigarettes, about a pack a day. And he desires treatment for hepatitis C, but feels like maybe it's too much. And in this new job, though he's really excited about it, he finds that his new coworkers use alcohol and cocaine, which he finds triggering. And he says about the cocaine use that it's harder to stop than he had thought initially. And he's upset that his daughter isn't trusting him to watch her children. So in practice, some of the things that we can use with contingency management, if we don't have, say, funds to purchase these specific rewards, the reinforcers are some other things that may be of benefit to the individual. So he found it helpful that we were able to provide bus passes, both for clinic, but also to get around to go shopping or to get to work. We were able to provide some meal support. And he had a interest in receiving a prescription for sildenafil, which is Viagra. And so we were able to use that as a positive reinforcer for reducing cocaine use. Some of the negative reinforcers to kind of remove the stimulus might be that he would receive fewer visits to the clinic, that he would receive longer buprenorphine prescriptions with take-home doses. So the good news is he still remains in treatment 2 years later, and all the previous things are still going well, and hepatitis C was cured. So he took a 8-week course of hepatitis C treatment. He did complete residential treatment for the cocaine use twice, staying on buprenorphine treatment, and did achieve 8 months of complete remission from cocaine use and started to be able to reconnect with family. And he did decrease the number of cigarettes that he was smoking. But, as life is challenging, and so is addiction and treatment of substance use disorders, and some challenges to continued. So he did have a return to cocaine use, but overall less than he had been using. So those are all great things. And he started to have some mood symptoms. So we added an antidepressant, and he decided to begin additional counseling treatment and intensive outpatient. So what might happen in more counseling treatment? So cognitive behavioral therapy can be in a group or individual therapy format. It addresses interpersonal and intrapersonal and social or environmental influences that maintain substance use problems. And so the focus in cognitive behavioral therapy is on coping skills, on cravings, on trigger management, on developing new reinforcing behaviors in life, and on increasing self-efficacy. Another kind of a modification of that approach is called a community reinforcement approach. So the goal there is to work towards pleasurable and healthy lifestyle activities that are more rewarding than one that includes drugs. So there are some structured, manualized elements to community reinforcement where the therapist explores positives and negatives of substance use with the client. They identify newer, reinforcing, healthier behaviors. So what are other things that you like? What else brings pleasure to your life? In the case of our patient, he really wanted to be able to spend more time with his grandchildren, and he felt that his daughter wouldn't be allowing him to do that if she knew, or if he was still using cocaine. And he also didn't feel that using cocaine was consistent with safely being able to take care of his kids or the grandchildren. What are some of the other areas to bring satisfaction with various areas of life and goal setting, and also some skills training, so improve communication, job readiness, and trigger management. There's a modification of community reinforcement approach that includes family training. So in this context, the patient has what are family or friends that are concerned significant others, and they're taught some contingency management principles to help facilitate positive behavior change at home. And it was developed initially to help people who are really very ambivalent enter treatment, work with the family and networks to help someone move along the ambivalence kind of spectrum to be willing to attempt treatment with medications. And then it's been adapted to improve retention and buprenorphine treatment. There are some virtual apps that use these principles of cognitive behavioral therapy and community reinforcement. They're typically interactive modules that focus on skills building and alternative positive reinforcers in the community that are not drug related. And some of the apps will provide, depending on whether insurance is paying, some contingency management with small monetary incentives for appropriate urines and completing modules. And the clinician can interact with these apps that the patient is engaging in to kind of facilitate the positive reinforcement. Network therapy is another type of approach that is manual based, and it focuses on training, again, the network members, so family and friends, to provide a supportive environment to support remission or recovery. So it brings the network for the client into the therapy session. And compared to medication management in buprenorphine treatment, there were over time some participants with a higher proportion of opioid negative urine samples, but this so overall, medications for opioid use disorders save lives. Counseling alone should not be offered instead of medications or as a required first step for medications. And behavioral interventions are a standard part of MOUD treatment already. Medication management and buprenorphine treatment is effective without additional specific counseling modalities. But some patients are going to have additional benefit. We can't tell who that might be among people that are entering treatment. And so we still recommend it. We still recommend counseling and community recovery supports, but importantly, not those that don't believe in medication. So if patients then are receiving medications, but then they enter a counseling relationship where there's a lot of stigma, or the person is told that they're not really in recovery if they're receiving medication, then those are kind of going at cross purposes and not effective in helping the patient do well.
And I will say that if you want to ask a question but don't feel like talking, you can always send me a question, and I'm happy to ask it on your behalf. I actually have a question. So is the reason that some of the additional behavioral interventions, is it a testament to the medicine, that the medicine is so good that you're not going to get any extra benefit, or is it that because it's built in with the counseling that it's just a lot, or what seems to be the reason that it's so effective, that the MOUD is so effective compared to the behavioral interventions?
As was reviewed in probably other talks about how opioid use disorder works, there are significant brain changes, and despite an individual person maybe wanting to not use opioids, once they have a severe opioid use disorder without medications, that's very, very challenging. And so a medication, yes, the receptors. So once the medication is there, and then that allows the brain to stabilize, and the person is able to then focus on other positive things that are not necessarily, the cycle of use, and then intoxication, or just of use to avoid being sick, cravings, withdrawal, etc. That makes it very, very difficult to focus on other things. So it's not to say, again, that counseling doesn't work. It's definitely very helpful for some individuals. The problem is that when people are entering treatment on a population level, what we know saves lives is the medication. And if somebody is dead, they're not going to benefit long-term from counseling either way. So what we know hurts people is requiring counseling as a path or an entry point to get medication. It needs to be the other way around. Once someone is started on medication, we need to think about treatment as a long-term process. And somebody might then, have some life challenges that while they're on medication, they may need some help to navigate. And counseling can play a very important role in that. Simultaneously, if there are some additional mood disorders at play, or other, so a lot of patients with opioid use disorder have histories of trauma. So over time, those are all important things to work on. Remember that a lot of these studies were over the short term. And so the mortality reduction we see is immediate. And then over time, whether we don't have studies that look at adding additional counseling over years. So I think the short answer is we never should use counseling requirements as a barrier to someone receiving a life-saving medication. And then we can always encourage counseling and try to explore with that person what the best fit for them may be. It may not be the first therapist or first approach that they find beneficial.
I just wanted to say something that I take MOUD myself. I take buprenorphine. And yesterday I was told at the clinic that they are no longer requiring groups and things like that to happen, that literally you just come in, see the counselor, and then see the doctor. That's it. So they're kind of changing things around in Kentucky, I guess, because before it was required that you do some type of peer support or counseling group. So
that's for methadone treatment, there are federal and state level regulations for counseling, but not for buprenorphine treatment in an office-based setting. But typically a lot of clinics will require that in some way. If someone is otherwise doing well in their medication, generally, as we've talked about, it wouldn't be recommended to have, like, if someone's otherwise doing well, but they miss some counseling appointments and they're missing them because of work or childcare or transportation or, very real things that happen. We need to not make it harder for people to stay on medications that are really very effective.
I agree with that. I think that especially with the methadone, and it being a daily thing that they have to come up with transportation, or like you said, I'm trying to work my schedule around when I go see my doctor, So it gets tough, especially if people are working and they have kids or different things like that. So I agree with that. I think, like I said, especially with the methadone, it's a daily thing you have to do for so many days before you can even get a take home. So it's definitely tough. I see that a lot with the participants we work with as well.
Yeah, thank you for sharing that. Also, some folks don't want to be in a group environment, and that's okay too. And some people find group really helpful. So it's definitely not one size fits all.
Less of a question and more of a comment regarding methadone. It was nice to see Dr. Volkov's comments on deregulating methadone. I don't know how quickly that's going to happen, but that would be a welcome change.
Yeah, I saw that. It's hot off the presses to have that kind of a statement coming from Dr. Volkov. Yeah, it'll be interesting to see. But making it easier to access medications that we know work is definitely essential.
So I have another question. In the studies, it looks like one of the studies was due to cocaine use disorder. So I have questions about other substances outside of opioids. Does it seem that things like contingency management and the other things mentioned, are they showing are they helpful for other substances like stimulants or methamphetamine and things like that?
For folks that don't have OUD, is that what you mean?
Yeah, I guess that's the question.
So for stimulants, cocaine and methamphetamine in particular, I wish we had a medication. There have been so many studies, unfortunately, and so many have not been effective medication candidates. Maybe we will at some point, but for people that have stimulant use disorders without substance use disorder, the most data are for contingency management. The challenges with contingency management is often funding. So there aren't a lot of models that allow paying patients for reduced days of substance use. And sometimes there are grant programs that you can use to buy gifts like we showed in the video. But again, that some of the studies are done with money, which is definitely reinforcing, and that's not something that we can kind of broadly make available to patients, unfortunately.
Right, because I was looking at that one graph where at the beginning it seemed to help quite a bit and then it leveled off between the groups. So is the idea that benefits, monetary, other things will get it started, and then once people start to see the benefits of the medication, it's less important, or perhaps?
I don't know that I can answer that. We don't have studies on, contingency management over years. I think, as somebody put in the chat, stimulant use disorders can be very challenging, and sometimes, we have to, make sure to keep encourage the successes. It may not be that someone completely stops using cocaine or methamphetamine, but maybe they use more safely. Maybe they stop injecting, maybe they use less frequently, maybe they reduce the number of days. All of those are positive things that over time really add up and make a difference in someone's risk of developing a complication or dying. And that eventually the majority of people do improve and do enter remission. And I think it's important to keep that perspective that people can and do get better. And if, that's that's a big reason to work on this overdose reduction, is because if someone passes away, they don't have a chance to get better. So with stimulants too, there's so much contamination now of fentanyl that that harm reduction there is really important, and making sure people have access to naloxone, not using alone, fentanyl test strips if they're available, things like that.
Just a question again. How, as a doctor, how do you treat someone with stimulant use disorder? Like, I'm not familiar with how that's actually treated. Mine was opioid use disorder, so I'm not familiar with how that's even treated.
Yeah, for people that don't have other substance use, again, the best evidence is for contingency management. I mean, we do recommend counseling and working on cravings management, trigger management, and using more safely to kind of reduce over time the risks of infections and overdose. It's similar approaches, it's just we don't have the strength of the medication. And John noted that we're going to have a 2-week series on stimulants. We can use medications to help people. So there are definitely withdrawal syndromes associated with stimulants for sure. And there are supportive medications that we can use to help people with those withdrawal syndromes. Sometimes we recommend residential treatment because getting a break and from the environment can be helpful as well.
Great, thank you for those answers. Does anybody else have any questions?
I was just going to make a comment that at my previous employer, we used a digital therapeutic called, I don't know if this one was called Paratherapeutics, but it's a contingency management app for patients. So it's, and this, however, I don't know, it was something that you actually had to write a prescription for. And I don't know if this was grant funded or if it was actually reimbursed by insurance, but it had patients do modules with a lot of CBT and repetition. And then once they completed certain modules, or if they had an appropriate urine drug screen, they would have a chance to spin a wheel, and then that wheel would have different rewards. So they would have like a gift card essentially options. So it's cool to see that they had developed something that could target stimulant use, even though we haven't found medications. It made me hopeful that maybe long term that could be more effective with implementing the contingency management on that end.
Yeah, that was there are some of those contingency management apps that are FDA approved. Oh, well, Catherine, you're getting a shout out. I'm glad to have her now at UK. But yes, they're not covered by all insurance, and but sometimes we can get it covered, and those are nice options too for some patients.